is one of our cardiothoracic surgeons here at the hospital. And without further ado,
thank you very much. Thank you very much, Rick, and thanks for coming tonight. Some of you I know personally. For those of you I don't, welcome. What I've been asked to talk about tonight is lung cancer screening. It's a pretty timely topic. Just as a background with regard to lung cancer, there's about 215,000 new cases described in the United States each year. And unfortunately, that leads to about 162,000 deaths. About 90% of lung cancer is considered smoking related. There are some other causes such as radon exposure, occupational exposures, such as asbestos, air pollution, and secondhand smoke, but those are a minor component. Certainly there are patients who do develop lung cancer who don't have a history of smoking, but the vast majority do. And this graph sort of describes that. Really, it parallels the rate or incidence of lung cancer along with smoking in the United States. And as you can see, the lung cancer develops, about 20 years after the patient smoked, but parallels that curve almost exactly. So again, as we've seen a decline in smoking in the United States, we're just starting to see a decline in the death rate associated with lung cancer. And this is another graphic from the Texas Department of Health that just basically overlies those two maps. On the left, it shows the incidence or prevalence of smoking based on counties. And if you look at Smith County, high incidence correlates very highly with the incidence of lung cancer. The state breaks us down into different areas, and we're in section 4. And when we look at the average annual number of new lung cancer cases for men and women, we get about 600 cases in men and 446 in women. So that's the second leading cause of cancer, or the type of cancer identified in our group. For men, it's prostate, and for women, the largest is breast cancer. But unfortunately, the death rate associated with that is much higher. So while we don't see as many lung cancer cases as we do prostate and breast, we see far more deaths. So it's pretty lethal. And in fact, there's about 486 men and 327 women who die of lung cancer in our area each year. So again, annual deaths due to lung cancer, 813. If you look at all other cancer deaths, colorectal, prostate, pancreas, liver, breast, ovary combined, only 744. So again, very lethal problem. When we talk about lung cancer, there's two main types: small cell lung cancer and non-small cell. Non-small cell is the predominant type, and it accounts for about 80% of cancers, lung cancers. There are different subtypes such as squamous cell or adenocarcinoma. Those are descriptive terms that we use to describe the pathology findings that we see. But we lump them together because they're treated the same way. The overall 5-year survival of patients with lung cancer in 1960 was reported about 8%. That's all comers, all stages. In 2009, it's about 16%. So we've made some progress, but still, again, fairly lethal problem. And that becomes that fact comes about by the fact that in presentation, most patients, about 75%, are in an advanced stage, and only 15% of the patients have localized disease. Again, in comparison, the overall survival rate for colorectal cancer is 64%, and breast cancer 89%. So we've made a lot of strides in treating those diseases, but again, lung cancer lags quite far behind. This is just a breakdown of survival by stage. Again, the point here is that earlier stage cancers, when we find them, do better. Obviously, late stage has a very low survival rate. Now, lung cancer screening has been, because of that fact that the prognosis is poor in advanced stage, there have been a number of trials that have looked at lung cancer screening. And there's a Mayo Lung Cancer Project, Memorial Sloan Kettering, Johns Hopkins. Most of these studies looked back at high-risk patients and basically looked at chest X-ray and sputum cytology. We had patients cough up some sputum into a cup and look under the microscope to see if there was any malignant cells. And unfortunately, none of these studies have showed any benefit. Some found cancers earlier, but they didn't produce any sort of survival benefit. Really, what's changed all that is the publication of the reduced lung cancer mortality with low-dose computed tomography screening. And basically, this refers to the National Lung Cancer Screening Trial. This was a study that was put together by the National Institute of Health, and it included patients from August 2002 through April 2004 at 33 different centers. In fact, over 53,000 patients were recruited, and they randomized into 3 annual screenings, so low-dose CT imaging versus chest X-ray. And really, the overall rate of adherence is excellent. That means the patients who enrolled completed all 3 of the screening scans 90% of the time. Overall, patients who had a high risk for lung cancer had a screening study. 24% of those showed a positive scan, and opposed to the chest X-ray group, which only had 6.9%. Unfortunately, there were a lot of false positives, meaning that we found a lot of nodules and things on the X-ray that resulted in a positive X-ray that weren't lung cancer. So that was one of the sort of downsides to the study. When we do low-dose screening, we find a lot of things. Unfortunately, not a lot of them turn out to be cancer, so that creates a dilemma. Overall, CT scanning had an incidence of lung cancer in 645 cases per 100,000 person years. That's how they calculate this. So look at per year per person. And that ended up identifying 1,060 cancers. When we looked at the chest X-ray group, it identified only 941 cancers. So again, in the CT group, there were 247 deaths from lung cancer for 100,000 patient years, and 309 in the chest X-ray group. So the relative reduction in mortality from lung cancer with low-dose screening was 20%. And that's really the basis for which lung cancer screening is now recommended. The fact that if we catch cancers early, we can reduce deaths from lung cancer. The low-dose screening CT protocol, this is just the specifics of it, but basically it uses a lower dose of radiation than a standard CT to do the screening. The radiation dose is measured in millisieverts, or this symbol up here. So the standard CT uses about 8 millisieverts, and the screening one's low dose, and you get about 1.5. And just as comparison, a standard chest X-ray delivers a 0.02. If you happen to work in a nuclear power plant, this is the limit that the government sets for you. And at about 1,000 millisieverts, you get acute radiation effects, nausea, white blood cell count effect. So just as a comparison. So which patients benefit from lung cancer screening? Well, in order to determine it, we try to look at patients who are high risk. So again, smoking history is a big one. Radon exposure, occupational exposure, history of cancer, certainly history of lung cancer, family history of lung cancer, other lung diseases such as chronic obstructive pulmonary disease or pulmonary fibrosis, secondhand smoke exposure, or signs or symptoms of lung cancer. Cough that doesn't go away, weight loss, coughing up blood. So we break patients down basically into 3 groups. Those are high risk, and is defined by the lung cancer screening trial. That's patients over the age of 55 and less than 74 who have greater than 30 pack-year history of smoking, or who have quit smoking less than 15 years ago. Or patients who are older than 50, smoke for more than 20 years, and have one of those risk factors. Patients who are in the moderate risk group, again, age 50 and 20 pack-year smoking, no additional risk factors, or low risk, age less than 50 and less than 20 pack-years. Really, there are no recommendations for screening. So it's really just this high-risk group that we now recommend CT screening. And the screening is the baseline low-dose CT scan. If a lung nodule is identified, then treatment falls into a different category. So if we identify something on a screening scan, then based on the size of the nodule, we recommend additional screening. If no nodules are identified, then the current recommendations for a repeated low-dose screening every year for about 2 years. Some people argue that you should do it indefinitely as long as the patient would be a candidate for surgery. So if there's no reason not to do it, meaning the patient's not so sick to have an operation, then you should at least consider it. Other patients, other findings other than nodules on there, could be coronary calcium, could be another lung mass, could be a big hiatal hernia, other things. Those then fall into that pathway for specific diseases that are identified. So you have say you have a lung screening CT and you have a nodule. Now what? Most people say, I need a biopsy. That's the first thing. Well, in fact, that's not really the case. Again, because 96% of the findings are not going to be lung cancer. So we've got to sort of weed through those to find out the ones that really are truly lung cancer or need biopsies. And really, the follow-up is recommended based on the size. Less than 4 millimeters, which is pretty small, we just recommended an annual follow-up for 2 years. So no specific intervention. The middle-sized group, 4 to 6 millimeters, we recommend follow-up in 6 months. Greater than 6 millimeters, but less than 8, follow-up in 3 months. And greater than 8, we usually do what's called a PET-CT scan. So that's additional testing. So it's those nodules greater than 8 millimeters that we worry about that have a much higher risk of cancer. So again, with patients who get a screening CT, the vast majority of these nodules are not going to require anything other than follow-up. But there are some that we do require additional testing and biopsy. And this parallels some of the radiologic criteria. This is a specific recommendation by Radiology Society as far as lung nodule sizes go. We follow that as well. There are also cases where no biopsy is necessary because it appears to be an obvious cancer. This is a picture of a patient, unfortunately, who had a squamous cell carcinoma. It has typical findings of spiculations, what we call those spikes that come out there. The center is necrotic and very hot on the PET scan. The likelihood of this being a malignancy in a high-risk patient, somebody who's been a smoker, is probably better than 98%. So again, a biopsy doesn't help us because a negative biopsy, we wouldn't believe. A positive biopsy, somebody's a candidate for surgery we can operate on. So again, we don't always do biopsies. We tend to reserve biopsy for gray areas. Patients who are non-surgical candidates, meaning they couldn't tolerate an operation, or have a history of lung cancer, we're worried about metastatic cancer or cancer spread from somewhere else, or we have a high suspicion of infection. And this is a good example. Here's a nodule on a patient. This turned out to be low-grade lung infection. So really the best approach for patients is a multidisciplinary approach. That's where we've got experts, pulmonologists, oncology, radiology, pathology, thoracic surgery, looking at these scans, evaluating the patient, knowing their risk factors, knowing their symptoms, and then determining the treatment plan overall. And that's what we hope to provide here at the Lewis and Peaches Miller Heart Hospital. We've developed a lung nodule clinic, which will be starting in July. And it's really, the focus is a multidisciplinary team of professionals who can provide consistent approach, consistent reads to the CT scan, and a complete array of testing procedures and treatments for the patients that need those. One of the pitfalls, again, is to develop, to do screening, and then every patient gets a biopsy, every patient gets a bronchoscopy. It's really not the most effective way of approaching this. Really, it's a case-by-case basis, looking at the scan, looking at the patient, developing a patient-specific treatment plan. So again, we try to develop a care plan for each patient based on their circumstances. So for the patient who comes in and has a scan, this is likely lung cancer. What next? What happens? Well, again, treatment options for lung cancer vary. Obviously, surgical resection is something that I do as a thoracic surgeon, but not every patient is a candidate for an operation. So chemotherapy, radiation treatments are options. Sometimes it's a combination of one or all three of these based on the stage of cancer in the patient. So in general, again, in general terms, the best treatment for lung cancer is surgery, if we can do surgery. And in order to determine that, we usually ask two questions. One, can the patient tolerate an operation? And two, will an operation be helpful? In order to answer those questions, we need to look, first of all, can the patient tolerate an operation? Do they have adequate heart function? Do they have severe heart disease? Would an operation be risky for them? What is their overall performance? Are they functional? Can they cooperate after an operation? Can they take deep breaths and walk and get up out of bed? And of course, do they have any additional medical problems, kidney failure, other cancers that may affect the operation? One of the screening tests that we use to determine if a patient in general is a candidate for lung surgery is pulmonary function testing. Basically, a breathing test that the patient take deep breaths and cough. And there's, again, these numbers are not important, but there are specific numbers that we look for on those tests. Does the person have enough breathing capacity to tolerate having all or part of the lung removed? And then again, we look at cardiac function. Does the patient have a history of heart disease, ischemic disease, no risk factors? Probably no further testing. But many patients who have been smokers, heart disease and lung disease kind of go hand in hand. So oftentimes, before determining eligibility for surgery, patients will require either cardiology evaluation or at least a stress test to see if their heart can handle an operation. And again, medical comorbidities are important, so a complete history and physical from the patient to know what their medical background is very important. So the next question is, will an operation be helpful? So we would determine that a patient can tolerate an operation, but really will it be helpful? And the question, or the issue that we're after is, can we achieve a complete resection? Operating on patients with lung cancer is often not helpful unless you can take it all out. If you have somebody with cancer, you do an operation, you get 99% of the cancer out, they still have cancer. So we try to avoid that. We use an array of tests to try to determine that. The lung low-dose screening CT is the initial test to identify potential cancers. But once we do that, and we've determined the patient might have cancer, we really do additional testing. So PET CT is the key test that we use in many cases. And then really we look at these scans to determine the size, location. Is there lymph node involvement? Is there spread to other organs? And if so, what do we need to do about those things? Really, to determine whether or not a patient is a candidate for surgery, we look at the stage. And the staging of cancer is based on 3 components: the T, N, and M staging. T stands for tumor, N stands for lymph nodes, and M is for metastases. And again, this is detailed, but based on the size of the tumor, which lymph nodes are involved, and whether it's spread anywhere else, that gives us a preliminary staging. And the lymph node, this is kind of a technical diagram, but lymph nodes that are in the middle part of the chest and lymph nodes that are in the lung are the 2 separating things. Lymph nodes that are in the lung, we can take out with an operation. If it's spread out of the lung into lymph nodes around the trachea or other structures, then we're kind of on the border for surgery. And that's what this staging breaks it down to. Basically, stage 1 or 2 cancers are usually considered surgical. Stage 3 are kind of on the border, and stage 4 are usually not considered surgical. And that's our treatment plan as well. So again, early stage A, we usually do surgery. Stage 1 and 2, usually surgery and chemotherapy. Stage 3, some combination of all 3, sometimes just chemo or radiation. And stage 4, usually chemotherapy alone, sometimes with radiation for specific incidents. So that's usually how it breaks out. The vast majority of people who get treated for lung cancer get some form of chemotherapy. A small portion of early stage, just surgery, some portion of late stage, just chemo. So again, this is a good example. This is a patient who had an early stage lung cancer, identified by CT scan. There's the cancer here. This is the PET CT image. PET CT, again, is a whole body scan that uses radioactive glucose to scan for any kind of cancers. The cancers tend to be more metabolically active, so they take up the tracer and they show up right on the scan. So we can correlate that with the CT image. So this is a patient who's gone to surgery. This is a patient, unfortunately, who we thought was an early stage lung cancer up at the top of the lung here, shows up right, but when we look at the PET scan, he had some lymph node involvement. So by definition, this is a stage 3A. This person actually still could be a surgical candidate, but would probably do better with chemo radiation up front, followed by surgery. So again, if you're not a surgical candidate, what other things are available? Well, then we start to look at diagnosis. Sometimes we have to get a diagnosis first if a patient's not a candidate for surgery or not a good candidate for surgery. So we can do things like CT-guided biopsy, mediastinoscopy, intraoperative biopsies, again, that's done by a surgeon, or sometimes needle biopsies that are done by a radiologist. Bronchoscopy, or endobronchial ultrasound, is a technique where we use a little telescope with an ultrasound probe on the end of it. We can put that down in the windpipe. It's usually done by a pulmonologist, and we can look at lymph nodes and biopsy them. And we usually have a pathologist on site to look at the biopsies right away and make a determination. And this is just another graphic illustration of how that happens. Again, with the ultrasound probe, we can look through the wall with the bronchi and identify lymph nodes and put the needle in there with your biopsy. Navigational bronchoscopy is a technique that we use occasionally to get out farther in the lung. The telescope size actually limits how far you can go out into the lung. But now with computer-aided software, we can take a CT scan, load it into the computer, and then use that computer to guide us out into the lung nodule itself. And again, this is usually done for biopsy. Sometimes we put markers in there to help direct radiation therapy for tumors. In the future, we hope that to have some treatment mechanisms available, either with freezing or radiofrequency ablation heating, so we can get a catheter out of the tumor and then treat it right then and there at the same time. Those aren't available yet, but these are new avenues that are being looked at right now in research facilities. And again, this is a CT guided biopsy. This is where the radiologist puts a needle right into the spot to get a diagnosis. Mediastinoscopy is a surgical procedure. Sometimes we do that when a needle biopsy is not diagnostic and we need to know for sure whether or not there's lymph node involvement. It's a surgical procedure done in the operating room. An incision is made at the base of the neck, and we can slide down with the telescope and get basically access to these lymph nodes that are around the windpipe and around the big blood vessels. So what about lung surgery? We decided that a patient has lung cancer and they are a good candidate for surgery. What does that involve? Well, it's an operation. The patients are taken to the operating room, put to sleep under general anesthesia, and we usually require special ventilation. So we can put a special breathing tube down the patient's airway that has a couple of balloons on it. There's a balloon on the tip and a balloon on the middle part. And we position it in the trachea, the windpipe, and blow up those two balloons. So now there's two channels. We can ventilate the right lung or we can ventilate the left lung selectively. And that allows us to do the surgery that we do. The approach that we use is either a thoracotomy, which is a big incision on the chest, or VATS. The majority of patients now have lung surgery for lung cancer via VATS approach, so they don't require the traditional big incision. And this is just a diagram that shows the positioning. The patient's laying in the operating room on the other side, then we make an incision between the ribs, and put a big chest spreader in there, spread it apart, and open up the lung. This is a big operation, a big recovery. We could take out either a portion of the lung, a small portion, it's usually called a wedge incision, a lobe. There's 3 lobes on the right lung and 2 on the left. This is the standard operation for lung cancer, is to remove a lobe if we can, or we can take out a whole lung. The more recent way that we address lung cancer is with VATS, or video-assisted thoracic surgery. And this is just a program. This is actually a little movie that we made showing the VATS operation. Turn the lights down. Thanks. So this is done with a telescope through small incisions, usually 2 small port access incisions, which are about 1 inch or so, and then we call a utility incision, which is about 2 or 3 inches. And we can look in there with the telescope, and we've got the lung retracted over, and we're just using a clamp here to free up what we call the bronchus. It's probably, I don't know how well this projects. So once we get that freed up, then we flip the lung back the other way. Now we're working in the front. Here's the heart, so right here, beating. There's the nerve, the front nerve. There's the lung, and we're kind of opening up what we call the pleura, which is that sac around the lung. We kind of free it up, and we're starting to get in view here now. Big blood vessel, big blue structure here coming out of the back of the heart. That's a pulmonary vein. And that's how the blood drains back from the lung into the heart. So we're going to get that freed up. That surgery, or this approach, is really kind of limited to earlier stage tumors. When there's a big centrally located tumor, it's difficult to move the lung back and forth, so sometimes we can't do that. Patients sometimes have had other surgeries, sometimes heart surgery or prior lung surgery. It can produce a lot of scarring and it can really limit what you can do with a telescope. Again, we're passing instruments around big blood vessels, so if there's a lot of scarring here, or there's lymph nodes that are sometimes adherent to the blood vessels, you can really limit what you can do with a scope. And we have to go to a procedure. There's sort of three main structures that we have to get around. There's an artery and a vein, and then the bronchus that supply that part of the lung. So here we're just getting a clamp around the vein. Now we got that freed up, and right behind the vein is going to be the artery. But before we get to that, we're going to actually divide that vein. And in traditional open surgery, we usually put a silk tie around there or a stitch and sew it up by hand. But now we've got little stapling devices that we use. So this is a stapler. It's got 6 rows of staples, and it's got a little knife that runs down the center part. So it kind of seals it and cuts it all in one motion. You gotta be careful pushing that thing through. You don't want to tear it. Once we're clear, we want to see the tip of it, make sure we're not caught on anything, and close it, and you can see the stapler fire. As it slides, the handle slides down and closes those staples. Take out the staple. So now there's the edge of the divided vein. There's the other edge. We grab it with a grasp or pulling it back. Now you're starting to see the artery coming. It's just this white structure here. So again, it's kind of, here's a lymph node. And the lymph nodes are closely related to some of the blood vessels in the airways and the lung. So we're freeing that, starting to free that up. And there's going to be a couple of branches. You can see an arterial branch coming off here. We want to save the lower part of the artery going to the lower lobe. So we've got to be careful about that. This whole procedure takes about 3 hours, so this is a pretty condensed one. This little video runs for about 10 minutes or so. This dissection portion takes a little bit longer than it shows. So again, we're going to clamp around. Here's the artery coming up into the upper part of the lung now. Clamp around that. And while this procedure is being done, the patient is just being ventilated on the left lung, again, because of that special tube. So that's why the lungs collapse and we have room to work in here. Now we've got the stapler in place. And we've divided the artery. These are little stainless steel staples and clips that stay in there. These are tiny. They look big on the projection because it's kind of magnified, but they're really quite small and difficult to actually see on even an X-ray. Okay, here's another branch. There's usually sort of 2 major branches that go to the upper lobe. We've got the first one and then a little smaller one right here. And once we get that artery divided, then the last structure is the bronchus, which is the airway going to the upper lobe. And that's right back in here. So as we kind of do each portion, we kind of expose the next one. So that's all the vascular structures have been divided now, and we'll go on to around the bronchus. Now we started in the back, so we've already dissected part of it. Now we've got the front free, so it's not too much more to do. And that stapler didn't divide it all the way, so we got a pair of scissors. Finish that up. Now we're working on the airway. Same fashion, we'll get that dissected free. Lower lobe, so we've got to preserve that part. We're going to divide it here. There's some lymph nodes. We take those with the specimen. Now we've got different size staplers for different thickness tissue. The first one we use is a white one. This is a green one. So this stapler is a little bit longer for thicker tissue, but it's otherwise the same. 6 rows. And again, we've got to be careful passing this around. The blood vessels behind here, the heart's back here, so we've got to watch to make sure we get the tip of that down so we don't catch anything. Divide that. So now we've divided all the major structures, the blood vessels, the veins, the bronchus. The only thing that's left are the attachments to the middle lobe. There are normally fissures or natural separation between each of the lobes. Some patients have a complete fissure where it's already separated. Some have an incomplete one. This patient has an incomplete fissure. So we're just dividing the upper lobe, here's the middle lobe and lower lobe. So now we can go right across there because we know all the blood vessels and everything have been divided. The staplers offer a big advantage to some of the older methods. In the past, before we had all these stapling devices, we'd have to put a clamp there and then sew that by hand. And you can imagine it's kind of like cutting out a piece of a balloon. It's still there. So every time you put a stitch or a staple, you can leave it. So the staples do a good job because there's 3 rows of them. It really seals it up well. We do have some sealants that we can use. We can spray it on the lung, try to seal it up as well. So there we go. We've divided that upper lobe. And then we put it in a big plastic bag. Pull it out. So again, the standard approach is a lobectomy, which we just saw. Sometimes we can do limited resections. We can take out a less than a lobe, a segment of the lung, but there's some controversy in doing that. It is associated with a higher local recurrence rate of tumor, and it can also doesn't really provide that much benefit in preserving lung function because a lot of the detriment in breathing is related to the incisions and the work that we do on the chest. So we really try to do a lobectomy if at all possible. The risks associated with lung cancer surgery, obviously bleeding, infections can be a big risk. The biggest risk is actually pneumonia. And one of the reasons for that is in order to do the surgery, we collapse the lung down and then re-expand it. And it can produce a lot of mucus afterwards, it can be irritating, there's incisions on the chest, it's difficult to take a deep breath and cough, or it can be, and patients can develop pneumonia. So it's really important that we get patients up after surgery, taking deep breaths. We use a little spirometer device that encourages them to take deep breaths and cough. Ear leak can obviously occur if there's a problem with the staple line. Sometimes in patients who have really bad emphysema, the lung tissue itself can be thin and tear, and they can develop air leaks or bronchial fistulas when you get a leak from the stump of the bronchus where we cut it. Arrhythmias are common, again, because we're working near the heart, and we keep patients on a heart monitor for a couple of days after surgery. One of the things that I like to do is I implant actually a pain catheter, a little plastic tube that runs along the ribs and infuses a local anesthetic for about 4 days after surgery, and keeps the area numb so that patients can get up early and take deep breaths and cough. And then most patients will go to the intensive care unit after surgery, at least for 24 hours, and then if they do well, they're transitioned to a low level of care. Here at the Lucent Beach Heart Hospital, we have a universal bed model. So patients go in one room, the level of the nurse changes around them. So the first night you have an ICU nurse, but after that, a floor nurse will take taking care of the patients. We don't have to move patients from room to room and floor to floor. And again, respiratory therapy, physical therapy are very important. Adequate pain control. We use beta blockers for medications to control heart rhythm, and we stop antibiotics early after surgery. Again, patients have a chest tube. It's a drain tube that stays in for a couple of days. Once that stops draining, we can take the tube out and let them. And we know that patients who've had lung cancer said successful surgery benefit from surveillance. So we usually recommend a CT scan every 6 months for at least 2 years. And again, usually yearly thereafter, as long as the patient's a good candidate for additional treatment. So in summary, most patients with lung cancer have advanced disease and presentation, but screening detects early cancers. And we know that when we find cancers early, we can treat them and patients can have a better outcome. Thank you very much. I'll be happy to take questions, I'm sure. And we'll put our phone number up here. This is our lung cancer clinic, our lung nodule clinic. So that's easy to remember. Thank you.
We need to just be sure that we don't have any prolonged coughs, right? That's what we would mainly watch for. Is that what I'm
Well, the most common associated thing with lung cancer is no symptoms at all, believe it or not. But certainly somebody who has a prolonged cough, coughing up blood, losing weight, pain. Sometimes people feel pain, but not usually. Those are all warning signs, and certainly any history of smoking with those signs, that needs to be investigated. Usually, these very minimum chest X-ray and now low dose screening CT scan. Yes, ma'am.
You removed my lower left lobe 5 years ago, and right now I'm just doing annual X-ray. Should I do the CT?
Yeah, I think that 5 years, you're kind of out of the recommended follow-up, after 5 years. But now, I think there are no strict recommendations for your follow-up, but I think it would be a benefit. I think it is, because if we catch it early and we can do something about it, I think it's a benefit. So the strict recommendations don't recommend any follow-up.
Not, okay, the chest X-ray not as good, though, is what you're
Correct, yes. Yeah, I would say if you're going to do follow-up, low-dose CT would be the best. Yeah, again, it's one of those things that people do a lot of follow-up chest X-rays, but there's never been a study that shows that it identifies lung cancer early or reduces mortality rate if it's found. So it's kind of one of those things that, well, we do it because it's easy and it's low dose. Maybe we'll find something, but there's no good data to support screening X-rays. Sure.
So when you have an annual physical, for example, I normally get a chest X-ray.
Right.
Are you saying that's not as accurate as this nodule thing?
For high-risk patients.
High-risk patients.
For high-risk patients. Greater than 55, greater than 20-pack year smoking history, still smoking or quit less than 15 years ago. That would be better with a low-dose screening CT than just X-ray. Again, the incidence of identification of early nodules with a CT was about 25%. Just X-ray about 6%. So it's much more sensitive.
And I've read that the PET scan is not as accurate as everyone thought. Is that true?
That's true. The PET scans are very sensitive, but not very specific. The PET scan will pick up an infection, lung cancer, granuloma. It'll pick up everything. So the sensitivity of the PET scan is very high. The PET sensitivity falls off for very small nodules, so less than 8 millimeters. So while it's sensitive on one end, it's not sensitive on smaller nodules. So again, when we select that test, it's for the right patient. When we've got a nodule greater than 8 millimeters, we're highly concerned that it's primary malignancy in a high-risk patient, then the sensitivity and specificity of the PET scan is about 98%. So again, if you just, that's why there's a lot of controversy about screening scans and screening CTs. If you apply it to the general public, the incidence of lung cancer is very low. So the likelihood you're going to find a cancer is very low. so the sensitivity of the test is not very good. But when you apply it correctly, so high-risk population, it becomes very effective.
Thank you.
Well, thanks. I'll be glad to stick around if you have questions you'd like to ask me, or if you have any questions for our nurse. I want to introduce Megan Morris. She's in the back. She's our coordinator for the Long Island Clinic. Rose Russell is our cardiothoracic surgical nurse. And Terry is one of the operating room nurses who works with us. So please feel free to ask some questions as well.
Thanks for coming out, Al. Again, feel free to ask questions, and we have some lovely little photo holders that y'all can take on your way out and talk to the nurses about the Dr. Castro.